if there are any questions, and people can also start raising hands this side as well. You can start in your room, Doc. Thanks.
Okay, sure. In my room, any hands, feedback, questions, input? Yes.
Actually wanted to find out if they've got
levetiracetam.
Yeah.
That tongue twister keeps getting me as well. So yeah, Sure. Thanks very much. So yeah, so there's a question in the room just asking if levetiracetam is available in the state sector. So yeah, I also wasn't sure, so I phoned the pharmacy now this last week. We do have it. Yeah. Any other input, questions, feedback in the room, on the line? Okay, I see a hand from Dr. Keert. Yeah, I think I'm semi the chair now. I'm just watching hands. Yeah.
Hi, Simon. Ursula Zalkier. I'm a pediatrician at Primary Healthcare.
Yes.
So most of our patients who present with status now will be coming into a primary healthcare facility, and especially CHCs or clinics. And it causes a lot of distress to them there because they don't have second-line medication available. Even our community healthcare centers now, if they don't make special arrangements with a hospital around them to actually send them, and they don't have it. So they're really stuck there, sitting with the patient, spitting away, and they only basically have diazepam. They don't even have any other fancy benzo to offer the patient. So how many times as to an adult do you think it would be safe to give a dose of diazepam? That's my one question. The other thing is, often the reason being given for phenytoin not being available at lower level facilities is that theoretical risk of arrhythmias. So in my experience dealing with children, I have never seen a child with a dysrhythmia while receiving it. So in adults, how big a problem is it? And should that then be a reason for us not having phenytoin available at CHCs and even our primary healthcare clinics, who are often hours away from higher level of care? So yeah, that is it.
Sure. No, thanks very much, Dr. Keert. Yeah, I think it's so important to raise these kind of very real concerns. And yeah, I've certainly seen patients. I mean, I'm based at CMH, and we've certainly seen patients where you've got these families that have struggled. I mean, they've been at the clinics and they've been trying to phone the ambulance, but it's taken 9 hours, or out of desperation, they've got a kind of private transport, and the person's been, as you say, fitting away, and it's horrible for everyone. I just got it. Okay. Oh, sorry, I'm not screen sharing anymore. But basically, in the standard treatment guidelines, you're asking how often you can give that diazepam. What I can see here, they don't kind of specify. They say if the seizure does abort after 1 or 2 doses of the benzodiazepine, then you'd also give your anti-seizure medicine, but it hasn't necessarily said how frequently or what your kind of dose that you can give is. The one aspect that they speak about is kind of the diazepam going to a maximum of 20 milligrams per dose, but I'm not 100% sure. I think not having phenytoin available is a problem, and it's something that should probably be, or should be brought up, because even in the standard treatment guidelines where they speak about giving the phenytoin, they speak about if a cardiac dysrhythmia does occur, then you interrupt the infusion temporarily, and then you reintroduce it actually at a slower rate. So within those guidelines, they actually speak about kind of what to do. So if you've got cardiac monitoring and you're able to see that occurring, then you've kind of been taking precautions to see if there's that cardiac arrhythmia that occurs. And there are good guidelines about how to run it in. So I mean, I know that you're part of the DCST, so you've got a lot of sway. So yeah, I think it's something that's worth bringing up. Yeah, definitely. Sure. Oh, sorry, Dr. Keert, hold on. Sorry, I've got a hand on this side. 30. Thanks very much. Thank you very much. One of the doctors in the room here, Dr. Comley, just gave advice, the answer about the diazepam. So you can go up to a maximum of 30 milligrams for status epilepticus. But that's giving it kind of at 3 separate doses, 5 minutes apart. Yes. Sure. So depending on the dose you're giving, between 5 or 10 milligrams, you can go up to a dose of 30 milligrams, and then that's 5 minutes between each dose. So you've got space to go with your diazepam, but yeah, to still make sure you're not getting respiratory depression.
Is it a follow on, Dr. Kit? There's a hand. She still has a hand up.
Yes, it is a follow-on, and it's specifically actually to you, Dr. J, and if you could maybe have a word with the provincial PTC, because I know from BCM that they have had a request for phenytoin at lower levels, and it's been at the provincial PTC for many months, and they haven't made a decision yet. So if you could maybe reach out to them and tell them that it is really an issue for us at PHC, the unavailability of the phenytoin. And then just another thing, but it's just in pediatrics, our second line medication before we go to IV phenytoin is to give the children phenobarbital. So sometimes when the sister at a clinic calls me and she has a child fitting away, we tell them to crush phenobarbital and to give it to the child with a nasogastric tube. So I don't know if that would be like a really way out suggestion for an adult who's sitting very far away from higher level of help to maybe help them temporarily while they are in transit.
Yeah, that's an interesting suggestion. Unfortunately, I'd have to kind of check up on that a little bit further. Interestingly, the guidelines do also. So again, this kind of comes back to that base question: Do you have levetiracetam available at kind of all levels? Because they do make provision for giving that oral crushed and given by nasogastric tube, and that would be for adults as well. So I think it would be good to hear from the as you're talking about the PTC and seeing how that does get distributed.
Can you, Doc? Can you look at the charts as well, Doc? There's some questions there.
Oh, sure. Okay. Chat. Okay, sorry. Sorry, I'm just going. I see there's quite a lot. I do see your hand, Dr. Lipepa. Sorry, Dr. Jacques just asked me to look through the chat.
Thank you very much, Doc. Can I ask, is it fine?
Yes, go ahead.
Yes, please. Yeah.
All right, Doc. This is a very interesting topic because we have this kind of patients every day. But I just have a weird patient that I've been seeing for years now. The diagnosis was made by someone else. I was not involved in the diagnosis, but I carried on the treatment. So now doing my own assessment and like interrogating the patient, examining everything, I found out that the patient is not having the usual seizures that I usually, the tonic-clonic seizures, is having like the absent seizures. So because they would tell me that she blanks out, and then she would be doing things, working and moving things and all those things. And then afterwards, she would wake up back. And so she's been on quite a few drugs. Epilim is one of them, lamotrigine, carbamazepine. She's poorly responding. I'm not sure if there's anything we can do for her, because I recently just found out that this thing that is happening with the patient. And when I checked with our pharmacy, there was nothing to give except the Epilim. Thank you very much, Doc.
Sure. Yeah, no, thanks very much for that question. And yeah, I think it's always good to try go through and try get that kind of deeper history about kind of absence seizures that could be occurring. It may also have been focal seizures with impaired consciousness. So I think that's also something to consider. And again, that kind of helps you to go through. Kind of with the treatment options, they often the guidelines speak about doing individualized to the clients, to the patients, and then that would involve trialing on a treatment that's the first line recommended one to do up to a therapeutic level, or up to your therapeutic dose, your recommended therapeutic dose. But in the guidelines, it actually also says some patients may need more, some patients might not need as much. So again, it seems very kind of nuanced between the seizure types with regards to kind of the pharmacological management. I think kind of with some of those aspects, a lot of the important things are, again, finding out the context around it. Kind of, I mean, it sounds like you did a kind of a really solid history, but obviously always to look back. Are they taking the medication? Are they taking it well? Are there any other aspects that might be inducing it to decreasing the concentrations? Is there possibly a stressor at home, something else? Is there something else that's causing these seizures? Is there something deeper that you need to be worried about? So I think what you need to do is maybe make sure that you're getting onto the right treatment. And then also in the guidelines, it does say that you should do, or you can do therapeutic drug monitoring for patients that have residual seizures, despite being on what one would consider to be the therapeutic drug or therapeutic dosing level. So that might have been an option. Did you perhaps do blood levels for your patient?
Sorry, Doc, can you repeat the question?
Sure. Sorry. So I was just wondering, the guidelines say that you could do therapeutic drug level monitoring, if the patient is on something that you kind of assume or they suggest is a therapeutic dose. Did you perhaps do any levels on the patient?
Oh, yes, Doc. This patient has been treated with multiple drugs over the years, and she hasn't been responding. That's why she's been changed from one drug to another. And she keeps presenting to our OPD we rotate. So from all the years, even before I was even at the hospital. So we've been doing the therapeutic levels, like we've been giving her the therapeutic dosage of drugs, because when you do the drug levels in the blood, they would show that they are within the therapeutic levels, and because she's been moving, she was initially on Epilim, and then we added lamotrigine, and then someone gave phenytoin, someone gave carbamazepine, and all of these drugs, their levels are in the file. Their levels are fine. They are therapeutic levels, and the improvement, there's none actually with the patient. Thank you, Doc.
Sure. Yeah, no, that's very interesting.
Can I come in, please?
Please, yes.
Yeah. Just to find out, Doc, have you ever done any imaging on this patient, like CT scan, MRI? Because remember, as the epilepsy is continuing, there could be mesial temporal sclerosis, which can be primary or secondary. So it's important also to determine that. And if no MRI has ever been done, you may find out that there might be other organic causes for this uncontrolled epilepsy, like AV malformations, dural, any vascular anomaly that could be there, that could be triggering a certain area of the brain to have this focal or whatever type of seizure, whether they're generalized or not. So my suggestion is that I think the patient has to be escalated towards imaging. We normally perform focalized I mean, we understand that sometimes we prefer that patients should be done first an ECG, I mean an EEG, but because of its unavailability and sometimes when it is available, it might be not adequately performed. So imaging sometimes will then come handy just to direct the way forward. I'm not sure where you are based, so that can be facilitated further.
Thank you, Dr. Comley. He is in Alwal North. You can respond to that, Dr. Lipepa.
Yes, Doctor, he was breaking up there and there. I couldn't make out, but I did hear about the MRI. I'm not
Yes,
sure if the MRI
my
was
suggestion
done.
is that contact Dr. Mali from Frontier so that they can organize for your patient to reach Frey and all the arrangements in terms of CT scan / I'll suggest that once the patient arrives there, both CT scan and MRI should just be done at once. So that trip is once and then the interpretation is done comprehensively.
Thank you very much, Doc. Thank you. I really appreciate this one.
All right, thanks.
Thank you.
Thanks very much. That's great. It's like a solid multidisciplinary referral team. I just want to see in the chat. I see one of the questions. Sorry, was in an ideal situation, how do we go about switching a pregnant mother from valproate to an ideal drug? With the kind of the section that I did there, you can't abruptly stop that valproate. You need to do your addition of your lamotrigine or levetiracetam in and titrate that up as quickly as safely as possible. So in high risk patients and with the quickest kind of up titration with your levetiracetam, I think that would probably be your agent of choice there. But again, that kind of comes down to when or if it's going to be available in the CHCs and PHCs. I think in situations like that, the patient should definitely be referred through to a higher level where they've got the ability to monitor that and certainly ability to keep patients on that treatment and have stock of that drug. Yeah, so it's a very good question, a very important question. The next question down was with children or adolescents that have been on anti-epileptic treatment from childhood and have now been seizure-free for more than 5 to 10 years, can we consider discontinuing treatment? Or is that not an option? So usefully in the guidelines, it does also kind of speak about that. So they say you can consider that epilepsy is resolved or no longer needing maintenance treatment in individuals. And then they say in cases that there was an age-dependent epilepsy syndrome that was the start of the epilepsy, and now they're past that applicable age, or they've remained seizure-free for the last 10 years. So they speak about kind of 10 years being their seizure-free period, and then they get slowly weaned off their anti-seizure medication for at least the last 5 years. So so they've been seizure-free for 5 years and then have not developed further seizures with the last 5 years of those 10 years, basically. And then you can consider that it has resolved and no longer needing treatment. Yeah.
Is that all, Doc? Thank you.
Those were the questions. Yeah. And there's been someone giving advice. Thanks very much. On the PHC centers from Dr. Kleiner, saying in children you can give up to 2 doses of diazepam, 0.25 milligrams per kilogram, 10 minutes apart. But at that point, needing the second dose, you should be on the phone to your referral center while preparing your phenobarbital 20 milligrams per kilogram. If there's no cardiac issues, if there are, then phenotone is the preferred option. So I think it's really nice what Dr. Kleiner is recommending there, especially in terms of the dosing, but also the importance of trying to get onto the referral center and EMS. Thank you for that.
Thank you very much, Doc. And thank you very much, colleagues, for joining today. The session is adjourned. We'll meet next week. Bye.
Thank you very much. Appreciate it.